So we've got a potpourri of discussions, and we'll start with Dr. Aditi Pujari. Welcome, Aditi. So we'll start with Aditi's talk. This is on managing ptosis in children for 5 minutes. Thank you.
Good morning, all. I shall be talking about managing ptosis in children. It's really nice to talk in some other subspecialty session when you're from something else. Yeah. So, as everybody knows, blepharotosis is upper eyelid position which is lower than normal. Simple language. Congenital generally presents in first year of life, non-progressive, and presents with or without association of other abnormalities. So what do I need to evaluate when I see any patient? So basically, first thing which starts with history, because we need to confirm it if it is really congenital or there is something else which is coming in as the etiology part. Visual acuity appropriate for the age is very important to rule out any amblyopia. Primary gaze will give some idea about the ptosis, whether it is mild, moderate, or severe, and that is going to help us in deciding if we need to go ahead with management. Down gaze will confirm if it is congenital, because there will be down gaze lid lag in cases of congenital ptosis. And up gaze is a surrogate measure of levator action. Again, MRD1 LPS action Bell's phenomenon, if we are able to examine it appropriate for the age, it will be great. Ocular movements is another thing which we surely need to see. So what are the objectives of ptosis evaluation? At the end of the evaluation, we should be able to tell about the type of ptosis, details of the ptosis. We need to at least make a protocol which surgery we need to perform, if we actually need to perform a surgery or we just want to observe. Desired amount of correction, if we need to overcorrect, undercorrect, or aim for a perfect correction. So there are a few associations which we need to rule in or rule out, which is BPES. Marcus gun phenomenon is very important, which is actually jaw winking in association with the jaw movement. Then there are other associations, which is monocular elevation deficit, again congenital fibrosis, DRS, Horner's, and though rare but not absolutely absent is ocular myasthenia or other NM junction disorders, which may or may not be genetically connected. This is one interesting case. This patient came to me with history of ptosis since 4 to 5 days. On seeing the older photos, it was actually absent in the previous photographs. So this was actually something acquired, not fitting in myasthenia, not fitting obviously in congenital, and not fitting in anything else. No congestion, no history of any foreign body fall or any trauma. So there was no clue. So the safest thing was to just wait and watch how the patient behaves according to the how the ptosis behaves. So to our surprise, it was this after just 15 days of follow-up without any intervention. Frankly speaking, I was clueless why it happened, but I just projected this photo just to confirm if the ptosis is not fitting in any classical examples. Just wait and watch and see the behavior of the ptosis before planning any surgical intervention specifically. So when do we intervene? When the child starts sitting and is awake most of the times, go ahead, you can plan intervention. Chin elevation is important indicator for planning a ptosis correction. Severe unilateral ptosis, surely you should intervene at the earliest because it may develop amblyopia. These kind of severe bilateral ptosis patients, we can wait or intervene because most of them, because of the bilateral nature, use their frontalis pretty well, and they may not develop amblyopia. So these are the available surgical options in general for ptosis, but most of the pediatric patient will, we need either levator surgery or tarsofrontal sling. So which surgery do we choose? Depends on the severity of the ptosis, LPS action, age of the patient, if you are planning for amblyopia correction or as a cosmetic correction. And obviously other associations like MED need to be tackled before going for ptosis surgery, because we need to take care of the Bell's phenomenon before we actually go and touch the eyelid. So this is my most favorite type of surgical intervention in ptosis patients in pediatric age group, which gives a minimal scarring, and we can actually take a call when they actually become adult and actually major a levator surgery. So these are the markings which I generally do, and this is the only incision which is taken just above the lateral part of the brow without any other incisions. And I use ethibond suture, either 30 or 40 as per the age. And it actually gives a very good correction with very much acceptable cosmetic things. Because if we want to do a tarsofrontal sling with it's just like Fox pentagon, but the incision is just a single one. So we can avoid the forehead incision. So it gives very good results with good cosmesis. And if the LPS action turns out to be very good in like adulthood, we can actually go ahead with levator surgery and avoid that forehead scar completely. And they do very well. This is 6 years follow-up post TFS ethibond. So these patients where the levator action is good, which is seen with the lid crease, which is formed well, we can actually go ahead and do levator resection under GA. And these kind of children where the pupillary axis is fine, but the child is showing some behavioral changes due to the ptosis, we can actually go ahead with surgery and get a very good outcome. One thing which we need to remember in these patients is primary gaze, it will give very good outcomes, but we need to preoperatively counsel about down gaze, lid lag, and lag ophthalmos, which is most of the times unavoidable if the ptosis is severe, which is very important because sometimes the relatives come and label this as a failure of the surgery and they do not like it. So we need to show them with the photographs preoperatively and make them mentally prepared for all these things. So just a technique message, proper history assessment, these are like to know the key factors in deciding the management plan, customization of the treatment, surgery, no surgery, and if surgery, then which one, and preoperative counseling about down gaze, lid lag, lag ophthalmos, and most importantly, possible need for revision surgeries is very important. Thank you.
So we'll move on to the discussion for this. So first we'll have Dr. Ramesh Murthy as a discussant, and then we'll have our chairperson, Dr. Meenakshi, to give some expert opinion as well. Ramesh, over to you.
I think that was a very good presentation, Dr. Aditi. So few things which are very important is the assessment of the child. So we have to specifically look for jaw winking and look for any poor Bell's phenomenon, look for other conditions like congenital fibrosis and the risk of amblyopia. If possible, always document by taking a vision and always document by photographs. The more important part is the counseling part and counseling the parents because they are the ones who are actually involved in this surgery. And so parents play a very important role in this, and if you don't take them into confidence, you'll be in deep trouble because patients will keep troubling you all their life. So post-op, we have to tell them very clearly that there's going to be lid lag, lag ophthalmos, and undercorrection, which is usually the rule in these cases. Always, we need to tell them that this is going to be lifelong, and the reason for doing surgery is just to get rid of the amblyopia. It's not a cosmetic surgery. In terms of surgery, I think sling is a very good option for these patients, even levator resection. But most important part is counseling. I did congenital fibrosis yesterday, and very big problem because I spent half an hour counseling the parents that this is not corrective surgery, this is purely for amblyopia reasons, and this is how this vision is. The surgical part is only 10 or 15 minutes. So the counseling plays a very big role in these cases. And if you have done surgery, then you have put your imprint on that. So you have signed on that eyelid. So that patient is going to follow with you all your life. So one needs to be extra careful about counseling.
That's great. That's very useful tip. Thank you, Ramesh. We'll move on to Dr. Meenakshi.
Yeah, good presentation, good discussion. And just a few quick take-home messages. If you have to take decision about ptosis correction in an infant, you have to have your indications very clear, which means you must know how to examine an infant for presence of amblyopia. So at least good qualitative, central, steady, maintained kind of vision assessment. The second is to ensure that there is no pseudotosis component, that this is not ptosis that is along with an MED. Because ever so often you see the ptosis is corrected and then they realize the highball is hypotropic. And that is very tough for everybody. The third important thing is if you do suspect that, or the parents say this ptosis is acquired, you have to rule out a Horner syndrome. And it's tough in an Indian population because the meiosis is not very easily picked up because of the dark iridis, and also because it's a child, and so you really cannot examine carefully and look for anisocoria. But that's where our smartphones come in useful, because they have a good gallery of all old photographs which you can quickly scan through. And if you do suspect that this is indeed acquired, you must proceed with investigation for potential Horner's and neuroblastoma. So it's a potentially lethal condition. So those are all I have to say. Thank you.
That's great. Yes, so looking out for these dangerous or sort of life-threatening conditions is really crucial. So thank you for that, Dr. Meenakshi. So maybe just before Aditya takes over, we'll just have one of the talks from the previous session, Dr. Leela Mohan, and she'll be speaking on evaluating an infant's eye and estimating visions. You have 5 minutes. Thank you.
Thank you so much, Dr. Meenakshi, and I'm so sorry for, I've been in this building for some time now, looking for the subspecialty hall, and I don't know whether I'm talking to the right people, because...
You've got there, you've reached your destination. Go on.
The convention center is as daunting as Mumbai for people like me from a small town, Chennai. Yeah.
Yes, I was told it takes only about 10 minutes to reach here, and that too. So, but I'm so thankful to have given me this opportunity to present it. Yes, this one. So, it should have been at the beginning, evaluating an infant eye and estimating its vision. So, visual and cognitive development should also be considered in these children. It's not just the examination of the eye. And it should be, the child should be referred to other disciplines if necessary, if the other cognitive factors are also abnormal. And rapid changes occur during the first few months, and delayed visual maturity can occur with no other ocular abnormality. So we have to see them again to see if there is actually a visual problem. And screening of the newborn can be done in the nursery, and if there is any abnormality, leukocoria, corneal opacity, prematurity, family history of retinoblastoma, cataract, congenital glaucoma have to be referred. And how do we go about it? Ideally, before the child gets upset, after a feed, after a nap, and we have to be quick in examination. And Bruckner red reflex gives good idea of the media, and structural anterior segment alignment, motility, visual acuity, and fundus examination. These are what we are going to look at in an infant. And of course, the red reflex gives us a lot of ideas about the media, anisometropia, strabismus, and pupillary abnormalities. And observation, while taking history, the alertness, fixation, and following has to be observed. And head and orbital and facial abnormalities can be noted. The ptosis examination is just over to see whether the child has a Marcus gun which prevents amblyopia. We can see when the child is feeding. And anterior segment, of course, we may have to see with the slit lamp to look at the anterior segment. If there is capillary hemangioma, we must see whether there is an anisometropia and anisoastigmatism actually. And if there is a larger segmental involvement, you have to refer to the pediatrician to see whether there is cardiac involvement and other face components are there. And specific examinations, depending upon the megalocornea, has to be investigated for glaucoma with an examination under anesthesia. And also, if there is a constant divergent squint, the strabismus, then we have to rule out other abnormalities, posterior segment and abnormalities as well. If the media is not clear, a B scan should be done also. And alignment, pseudostrabismus can be very, parents may come with the suspected squinting. And a simple cover test, as you see here, the child is looking with his left eye. And when covering the left eye, he is trying to look with the right eye and see whether there is equal fixation. And nystagmus and head posture can be seen, and whether they have to be immediately looked for other associated pathologies, a head nodding, and here there's a pathology, bilateral cataract. And looking at the corneal light reflex, free alternation can be seen even as the child is looking at you, and cross fixation is there. Krimskis can also be seen with the loose prisms. And visual acuity, of course, we have to see what is the age of the child. Infancy, there is development from eye contact to alignment of the eyes, and then reaching out for objects, recognition of pictures, and fixation and following of both eyes, and then unilaterally also we have to see. And then if there is, as we have seen, a cover test will show you whether the child prefers one eye. So according to the CSM, that is whether the fixation is central, steady and maintained, we get an idea of if it is central and steady and maintained, it gives a vision of approximately better than 618. If central and unsteady, it is less than 618 to about 636, and if it is not maintained, less than 660. And not taking up central fixation, it's a few meters, like less than 360. And after patching uniocularly, you can look at all these fixation patterns also, whether he is reaching out for objects, smaller objects you can see, and okay in drum also, after patching it can see whether the eye is moving for the smaller stripes. And hundreds and thousands sweets test. You can increase the size of the sweet if he is not picking up the sweets, and then see whether he can see. And a 1 millimeter at 1 foot distance corresponds to 624 vision approximately. And preferential looking test, teller acuity cards are the most reliable, and we can see at about 38 centimeters for children up to 6 meters, and above 6 meters at 55 centimeters. The finest grating he recognizes gives the visual acuity. And the other preferential looking tests are the Leah paddles and Cardiff acuity cards. Again, it is a preferential looking where exactly the child is looking at. And the pattern VEP gives the cortical response to a visual stimulus entering the eye, which is objectively recorded. And the check size, contrast, luminance, and frequency can be changed. And sweep VEP is faster and for a younger child and more easier to do. But it is more expensive, and the interpretation should be by a trained personnel. If there is a lot of sound, noise in the room, it is difficult. So, of course, the fundus examination in premature babies, we have to dilute, half dilution of the usual adult dosage of tropicamide, phenylephrine hydrochloride is used. And in a strabismus, we may have to do cycloplegic refraction in older children. I mean infants, but older infants. Thank you so much. Thank you.
Thank you, Dr. Leela Mohan. That was a great talk. And I'm not sure if we have Dr. Priyanka Bormani as a discussant here. Is she there? Hi, come forth, yes.
I think ma'am has covered everything very well. And I think what we must try is tests which, do not involve touching the child first, can be done first. So because it's a small child. So let the child get comfortable and then do. And also pupillary reactions are a little difficult to assess in that age group. So instead of we using a very bright light, we can already keep the room dimly lit, because many times the pupils are already small or constricted. So for a better assessment. Thank you.
Okay, we'll move over to Dr. Meenakshi for some tips. As we always know that it's a small window of opportunity when we're actually examining the child. So let's see what window Dr. Meenakshi shows us.
First, I wanted to congratulate you on the excellent videos. I think I know how busy your practice is in Comtrust, Calicut, and you've taken time to shoot videos of different types of tests in children. And also the high standards that you guys practice in Calicut Contrast of pretty much you have every possible way to examine an infant. And you don't have to worry that your talk was in the wrong session or in the wrong order. I think examining an infant is pan-ophthalmology, whether you're doing cornea or you're doing retina, you have to deal with infants and you have to deal with infant vision. So I think it was perfectly situated between ptosis and cataracts. So thank you for a lovely talk.
That's great. Thank you so much. So we'll move on to the next speaker. This is Dr. Aditya Seth. He'll be speaking on pediatric cataract. Sorry.
Misprinted.
Pre and intraoperative pediatric cataract. Over to you. You have 5 minutes.
Thank you so much. First, I'll start by thanking AIOS for bringing all of us under one roof after so many years and giving me an opportunity to present in front of my seniors, teachers, colleagues, and friends. I'm going to be talking about pediatric cataract, the pre and the intra part. So I have no financial disclosure here. So this is what I ask myself when a pediatric cataract comes to me. Can I have my presentation? So first question I ask is the cataract visually significant? Can vision be improved with surgery? Second question I ask is when to operate, when to put an IOL, what formula to use, what is my target post-op refraction, and how different is this procedure going to be from an adult cataract? The other two questions will be taken in the next talk. So what is a visually significant cataract? I think this is very important for all of us to know that visually significant cataract is in the central visual axis, is bigger than 3 mm. Posterior cataracts, no clear zone in between. Retinal details not visible with direct ophthalmoscope. Nystagmus or strabismus present and a poor central fixation. And often this is misunderstood that amblyopia needs surgery, which I think is not always the case. These are a few of the different types of cataracts we see. So ask yourself this question, can vision be improved with surgery? Check with a direct or an IO for red reflex in the size of the cataract. If one can view well with a direct or IO, you can reconsider doing surgery immediately. Objectives of the surgery should be to clear the central optical zone, remove scaffold for PCO formation, maintain support for IOL, should be least traumatic for the child's eye, and minimum complications should be assured. Maintain the rim and document in case you're doing a planned aphakia. So what is the timing of surgery? Remember, if it's visually significant, earliest is the best, and in unilateral, earlier than earliest as compared to the bilateral. High risk of glaucomas in very young children has been documented, and consider corneal diameter, the size of the eye when you're doing examination under anesthesia. Also consider GA risks. There are higher chances of post-op apnea in 1 to 2 months age group. So we have the unilateral study, the IATS, which has given us very good guidelines, and the bilateral cataract study, which has come from India itself, which has compared the onset of cataract, the timing of cataract, and whether the IOL should be implanted. So when do you put an IOL? The general consensus now is IOL for most children. Unilateral cataracts, IATS also talks about leaving them aphakic. The benefits was weighed only for unilateral cataracts. The bilateral cataract study by Dr. Vasavra also considered the age, diameter, and the axial length whenever you're deciding what IO formula to use. A lot of papers are there, and SRK2 has been the least variable and often used. I also prefer to use the Barrett's calculation because it's much easier nowadays. The thumb rule, when you're talking about myopic progression, that I use is the rule of 7, where I use the age and the target hyperopia, and the total should be 7. This is usually for 7 years of age or less. So how pediatric cataracts differ from adult? It's a unique challenge. Anterior chamber can be unstable, increased capsular elasticity can be there can be decreased scleral rigidity, higher tendency for PCO formation, and nucleus is soft and easy to aspirate as compared. The first thing I want you to know is about your GA. So remember to know what sort of GA will suit you. If you're a beginner, maybe intubation would be a better option than iGel or a LMA. Also, a little bit of muscle relaxant should be given. Use a head ring and shoulder support because remember, you can't manipulate the head during surgery. So handling of the anterior capsule, when you're talking about the anterior capsule, the dilatation is quite good with 1 lakh adrenaline. Stain with trypan blue. Elasticity is different. Always inflate the anterior chamber very well. Overfill it for better control. And use high density viscoelastics if required. Grasp, re-grasp, and then complete your X's by pulling it towards the center. Alternative method, Dr. Nischal has shown in younger children his push and pull method. You can also use a Victorexis technique, where you can put a cut rate of 150 to 300. I prefer to do this only when I'm doing a lensectomy, planned aphakia. So lens aspiration, remember to do a multi-quadrant hydrodissection. The advantage is the reduction in operative time. What I would want you to also take home is always strip the cortex from periphery to the center first, rather than eating the nucleus, because in cases of traumatic cataract, when there can be a PC opening, it may lead to complications if you don't practice this regularly. PCC for all cases under the 7 years. I even do it for older children because it's very difficult to get them under the YAG laser later. So underfill the bag. Let the PC come up a little bit, take vertical nick, and then use your excess forceps. Then you can push a bit of viscoelastic in the Burgess space so that you have better control and you can make the posterior capsular excess complete. Anterior vitrectomy, the idea is to clear the visual opacity. There should be no visual opacity later. So go ahead with your vitrector, put your port down, go into the PC opening. The end point should be when the PC margins curl and fall back and the round shape of the posterior capsular excess is maintained. You can use tricort or you can use your the spatula to make sure that there's no vitreous in the AC and the PC is round. You also have the vitrectomy approach with a vitrector. IOL insertion and choices, always prefer in the bag because this is a long-term output you're looking for. So single piece IOL in the bag or a 3-piece in the bag or in the sulcus is a good option. Always keep a backup IOL because pediatric cataract, you never know what happens and you have to assure that general anesthesia is given only once. Can consider the latest locking in or the IOL technique. Remember, it's like a plane landing. So when you're injecting the IOL, make sure it's leading haptic down into the bag, and once you're reaching the bag, just pull up. Closure, always take a suture. 10-0 vicral wound sutures have to be taken. And now, in conclusion, proper evaluation, medical surgery, correct follow-up, and amblyopia therapy will lead to good results for your children. Thank you.
Okay, great. Thank you, Dr. Sethi. And we'll move on to the discussion for this talk. And is Dr. Love Koshave around? Dr. Love? Okay, so so just to have some brief discussion on your pre and intraoperative, we'll start with Dr. Meenakshi. Okay.
I thought it was going to be very special. Both are my fellows, Dr. Love and Dr. Sethi. But lovely talk, Aditya. And people have whole ICs on pediatric cataract. And here, I think your magic was the brevity. You used cute little videos to highlight all the steps. So wonderfully done. I'm just going to say few quick points. So when you have a white cataract staring at you, it's it's no brainer that this needs to be out. What really challenges you are when you have these haze, unilateral haze, especially when kids who have used, say, self-medicated with steroids or uveitic cataracts, or you have traumatic cataracts, which you're following, and if slowly the haze is creeping up, and that's when, for you to take a decision whether this, cataract needs to come out is the real challenge. And I would only like to say that two very important things. One is make sure you refract the child at, this good cycloplegic refraction, and give a trial of glasses, spectacles, and also do adequate amblyopia therapy to make sure those components of the decreased vision are taken care of before you decide that this cataract needs to come out. Anything you would like to add, Manju?
Yeah, so these were really good pointers. Maybe the other thing I would like to say is it's not just the cataract, but also look at the child as a whole. Look at the family as a whole. We need to treat that family, look at other siblings, if at all, or extended family, to try and find out why this cataract has happened. Is it going to is it something familial that may happen for the children down the line? And many a times this is a thing that the parents have to deal with throughout the life, that as long as they are alive, and they want the best for their children. So breaking this news that the child has cataract, we need to give adequate counseling time to actually break that bad news that this is something which you have to deal with, but there are ways and means to improve the vision and sort of break the news, but also give them hope.
Yeah.
I would just add that. Thank you.
Can I ask a small question?
Yes, sure.
How often do you notice the motor anomalies or abnormalities and VEP abnormalities in congenital cataract that has not been operated till the age of 2 years?
Not doing VP regularly for these children. Whenever I see it's.
Okay. What about the motor abnormalities, congenital
Yeah.
cataract?
That does happen. That happens.
How often do you notice?
I would say, sir, maybe 1 in 10, maybe 1 or 2.
We see them, I would say, a lot more. A lot more, yes.
Squint
And
maybe
as the child gets older,
head
the
nodding in his
frequency
times.
will also be much more, yes.
Yeah.
Yeah.
The reason I ask that question is because if you notice the motor abnormalities in congenital cataract, like if you notice the motor abnormalities in congenital cataract before surgery, then you need to give a very guarded prognosis. And if you notice that there is head nodding, there is nystagmus in these children, you can do VEP after surgery, because before surgery VEP does not give you any information. And if you notice again VEP abnormalities, you need to give a very guarded prognosis for these children, because I treat so many of these children now who have done wonderful cataract surgery, but eye is nodding and they're doing all that. With my instrument, they have improved. They have improved up to 6'9". Many of the children with unilateral cataract, congenital cataract, operated at the age of 2 or 4 years. There was a recent article where it showed what VEP abnormalities are seen in congenital cataract not operated for long.
Thank you, Dr. Gopal. That's a really useful pointer. Thanks for that. We'll move on to our next speaker. So do we have Fatima A? So Fatima A is going to be. Right. Yes.
So whenever the horizontal diameter is not appropriate in 2 months, we generally in these cases in IITS they have mentioned that as well, that the smaller the eyes are, the more chances of post-operative glaucoma and everything.
In general, the chance of post-operative glaucoma, whether it's aphakic or pseudophakic glaucoma after cataract surgery, is high in children. Younger the child, higher the chances. So, definitely something for bilateral. We do still follow that around 6 to 8 weeks is a more more optimal time than going in really early.
Along with that, the general anesthesia risks are much more when it's less than 6 months. So you have to weigh both.
Yes. Right. Yes. That, yes. Yes. Yes, it's always a very tough family situation, but we sometimes need to go beyond the call of our duty in offering this counseling. You also had a question?
Ma'am, I just wanted to ask about a patient who has a Marfan syndrome, 8-year-old child. One eye, asymmetrical subluxation of the lens. One eye has got a definite subluxation which will need fast canal resection. Other eye has not got that much of a subluxation. So what would be the panel or your choice for putting the IOL in the same sitting with a back fixation or doing a sclerosis?
Yeah. So we're just going to say that. Let's hold on to your question, okay? You might get the answer coming up soon. There is a talk coming up. So if Fatima A is not around for post-cataract pediatric surgery, we can have the discussion. Is he there, Dr. Jaspreet Sukeja? Or maybe we can just skip that if they come in later, and we'll move on to the next talk. So there comes the answers to your question. Dr. Kavita.
And I have another fellow in the audience. We're very proud of our fellows, Dr. Kaushik. We didn't mean to be color coordinated, but I think when the camera's on us, please take a photograph.
We are Hyderabad and Chennai in love with each other. Okay, so Dr. Kavita will be speaking on ectopia lentis. And the discussant is Dr. Sharad Bomaj. If he's around, you can be ready as well.
At the outset, I thank the committee for giving me an opportunity to talk on ectopia lentis. I have no financial interest in this presentation. All of us know it is the lens not being in its original place, that is the patella fossa. There are many causes. It could be congenital or associated with syndromic or metabolic causes, most common being post-trauma, and it can also be spontaneous. There are various syndromes. Marfan's homocystinuria, Will-Marchesani, and sulfite oxidase deficiency and hyperlysinemia. One clue is the way it is subluxated. We can take a clue on to the diagnosis along with the other clinical evaluation. The clinical features being pain, redness, depending on what it is, how the patient is brought in. Most common being defective vision. There could be monocular diplopia and associated amblyopia. Ectopia lens could be a total dislocation into the anterior chamber or into the vitreous, or that could be subluxation of various degrees. So you'll have to examine for the aphakic portion and the phakic portion whether you really want to conservatively treat these children or you want to take these children for surgery. The other factor which gives a clue is whether the lens is cataractous as well. And other features are associated secondary glaucoma features, as you can see in the picture on the right side above, is the ciliary staphylomas which is there. And this lens which is totally dislocated into the anterior chamber. We also need to keep in mind the predisposing factors for retinal detachment in these syndromes. Yet another factor is the systemic evaluation, which is very important in all patients without history of trauma, cardiac evaluation, and in my personal experience, evaluating for homocysteine. So these children are likely to get thromboembolic phenomenon during general anesthesia, which we have seen. So spectacle correction, as I said, through the phakic or aphakic portion, I would prefer if the child is getting good vision, just defer surgery. Laser PI can be done associated with shallow AC and good vision and no symptoms. Mydriatic if the lens is dislocated anteriorly. Depending on the zonules, how much it is weakened, we can think of CTR, Sioni ring, and Ahmed segments, and also capsular retractors, and then think of, along with anterior vitrectomy, we can think of scleral fixated or iris fixated. But in case the eyes are having microcornea and microophthalmos with shallow AC and posterior dislocation, better the vitreoretinal surgeon takes over. There are two options. One is the iris fixated and scleral fixated. Both has plus and minus points. I prefer the iris fixated, although initially I started with scleral fixated, which takes much more time. Role of femtosecond laser is very useful when you see my video here. Depends on the degree of subluxation. Definitely femtosecond helps in creating predictable and centered capsulotomy, which helps in successful placement of PCIOL. So I'll just run the video for 4 minutes now. This is like more than 180-degree subluxation. The zonules are so weak. Especially so if the eyes are myopic, the zonules can be weak. But otherwise, you could, one can really achieve a good rhexis here. I'm completing the rhexis. This is followed by a general hydrodissection. I just infuse in all quadrants. And I aspirate using the same cannula, or you can use the viscoelastic cannula, which is 23 gauge. The capsule can be easily removed, but in some situation the capsule is quite tough. Probably you could use the vitrectomy cutter to remove off the capsule. This is followed by a good anterior vitrectomy using 2 side ports. I have closed the main tunnel with a X suture and just turning the cutter and do a small PI at 12 o'clock. In some situations you can have a bleed there. Here I didn't have. This is another situation where the lens is totally into the anterior chamber. I did SICS. I'm just removing that. Now coming to the iris fixated lens to be implanted, do make 2 side ports 180 degrees apart. Don't make it like a tunnel, just make a stab incision. This enables us to easily achieve a proper enclavation of the claw haptics. I use heel-on so that the chamber is tight. And the other thing is, initially I used to do it as a primary procedure, but later I realized that because you would have done vitrectomy and the eye would be soft, I prefer to do it as a secondary procedure. So I get a good round pupil post-operatively. So I use a straightened dialer to enclave. Here the clue is just lift the lens slightly above. That is, you can see the haptic below the surface of iris. And then you get a clue that the haptic is there, and then you just give a tuck. I use heel-on here at this step. So you have intraoperative round pupil. Sometimes, because nowadays it is 12 mm overall length, we are getting slightly oval pupil. This is a case where the haptic is got disenclaved after few years. So there's nothing to worry about it, just go back and then enclave it. But in case if it is disenclaved and it is behind, then it is better to refer to the vitreoretinal surgeon. They will put a port and then lift it from behind and tuck it. You can see the PI as well. This is a situation where there's secondary glaucoma with ciliary staphloma. I did using a side port. I removed the lens. I didn't place an IOL here because the first criteria was to remove the lens which was causing glaucoma. Thank you.
Great, that was very nice videos. Thank you so much. Is Dr. Sharad Bomach, yeah, would you please like to take over the discussion?
So with the ectopia lentis, the main thing is indication for surgery. If the lens is clear, significant portion of the lens is clear and occupying the pupillary area, and you are able to do a good refraction, we should not operate. So the indication for surgery is important. If the lens is in the mid-pupillary area and the lens edge is causing a lot of refractive problems, high astigmatism, or if it is totally subluxated, dislocated, then these are the indications for surgery. So with a subluxated lens with a clear visual axis, you should aim for refraction. That is the first thing for indication for surgery. Then technique for surgery. It depends on the status of the zonules. In many patients, though the lens is ectopic, you will be able to do a good rhexis and place a CTR or fixate the bag with the Cioni ring to the sclera and put in the bag IL implantation. Though this is the ideal thing, it is not technically possible to do it in every case because it is technically challenging to get the thing right every time. So consistency becomes a problem. So in those patients, we should aim for lensectomy, whichever way the surgeon is comfortable with. So obviously, if it is totally dislocated, then lensectomy is the treatment of choice, technique of choice. The next thing is aphakic rehabilitation once you remove the lens. So obviously, if the eye is inflamed due to any cause, then we should not do a primary implantation, wait for a couple of weeks. And second thing is if it is unilateral or bilateral. So in bilateral ectopia lentis, where you want to do a bilateral surgery, I would prefer to do a aphakic correction for these patients till they reach the age of 15 or 16 years. Many times these patients are having pre-existing myopia, Marfan's, many retinal problems. So there should be no hurry to do a IOL implantation, especially in bilateral ectopia lentis. I would prefer to wait for at least 15 to 16 years of age, give them refractive correction aphakic glasses, and after that we can plan the optical rehabilitation of aphakia based on the technique, iris fixated, SFIL, whatever the surgeon is comfortable with. The next thing is the follow-up. So basically, the lifelong follow-up is required for all these patients of ectopia lentis. Many patients are having coexisting retinal problems, so they need thorough evaluation of the retina. They need repeated refraction. So the refractive status of the child with an ectopia lentis keeps on changing. So the lens which you have implanted, suppose at the age of 4 or 5 years, by the time the child reaches 10 or 15 years of age, they will have a significant myopic shift. So that is why we should not be in a hurry to implant IOLs in these pediatric patients. So wait till 15, 16 years of age and then do a IOL implantation. These are some few important points which I wanted to discuss. Thank you.
Thank you so much. And we'll just like some expert comments from our chairperson now.
I'm so tickled every time you say that. Just a very practical point. So you have these little kids who are 3 and 4 years of age, and you can, when you do refraction, you can see that there is a little bit of subluxation, and that is when you have a tough, first of all, good presentation, Dr. Kavita, great videos, and a great discussion as well. We made very good points. Dr. Sharad saying that don't rush into trying an implant on IOL. I think it's a very valid point. Sorry. So you have a little kid, and then you can see a little bit of subluxation as you're doing your refraction. And that's where you are not sure. This, the phakic portion is high myopia, and then you see a little bit of a phakic portion. You're not sure what to prescribe. That is often the way it presents. It can present. So in such cases, my approach has been, our tendency is to prescribe whatever is the maximum pupil coverage, which is myopia. But tell the parents, bring the child back within a month. Ask the parents to observe how's the child's behavior. If the child is preferring a phakic portion, the child will have a hard time with the myopic glasses, will try to look over the glasses, will be doing all kinds of funny things at home. And then in the clinic, you just have to slip in that aphakic portion in front, and the child will immediately brighten up and start reading. Then you know, even if the aphakic portion occupies only 10 or 15% of the pupil, that is preferred by the child. That's number one. Number two is the thing about surgery in Marfan's particularly. There are a lot of articles that have shown that the incidence of retinal detachment is higher in Marfan's children because of also the coexisting high myopia and higher incidence of lattice. So keep that in mind when you decide you want to go ahead and operate on a Marfan's patient for the ectopia lentis. And these pupils notoriously don't dilate. So if you are not happy with the view you're getting, before you finish your surgery, or even as an EUA, have your retinal colleague take a good look at the retinal periphery of these, particularly the Marfan's kids. Thanks.
Thank you so much. Yes, that's...
After the 6 months to a year after the squint surgery, he came with bicycle eye in one eye because the retina had detached completely in one of the eyes. Now, whatever you do, you can't examine. I finally did the ultrasound to see the back of the eye, and it was okay. I said, look, right now it looks all right, but I don't know what is wrong in this eye. But what do you do? Pupil doesn't dilate. So I didn't have an answer. What do you do? What do you suggest that we do for these pupils?
These are very tough. But I think our retinal colleagues, fortunately, perhaps are better at examining patients with lesser pupillary dilatation. So I think it's worthwhile, especially in your case, when the child has now become monocular because of phthisis, is to refer the patient for maybe a good EUA. Where they can really, press and prod on the eye and then try and look at the periphery. That's all you can do.
Also think of a UBM to see how the position of the lens, where it is, how much is the subluxation. if you're not getting a good view on a slit.
But I think these are all mesodermal problems, the markings. And
Yes.
therefore there is a problem in the iris as well. That's why
Yes,
people
yes.
dilate.
So again, look at the patient as a whole. Look at his heart as well. Okay, let's move on to our next. We are just. I haven't. Most of mine are the lenticular myopias, not so much the axial. So yeah, yeah. No, it's more the vitreous that is then pulling and causing the retinal detachment post surgery, I would say. Yeah. Yes.
Question like that, if you plan to do SFI in early teens in such case, do you prefer call your retina colleagues and do the prophylactic vitreous depth resection to avoid the later on iris?
Would you like to answer that question?
Depends on what they have seen with the visual retina. And generally they have lattice degeneration with Marfan's case. No, they wouldn't be advising this. If there is lattice and even if it is having a hole, even atrophic hole, they wouldn't want to laser it.
Yeah.
Lattice they usually follow. So I had recently a child who I had operated about 9 years back bilateral. So now he has developed early. There was no lattice. He was on retina follow. So as Rahman said, there will be no predisposing factor. But later on they developed lattice. First was the retina follow. So we can, but
Let's.
last follow-up we saw the patient was doing well and suddenly the patient has developed eye. So is there anything prophylactic that we can do previous? Because I don't think I are predisposed. What I am thinking, I am not sure, but probably lattice there was some certain follow-up. But in pediatric as a prophylactic, I have not seen mine, but
Yeah, well, when the hall fills up, it means the next session is coming close. And people have already started coming. So we have 2 more talks for interest of time.
Yeah, the
we'll move
ROP update is Dr. Sangeeta Roy or Dr. Aditi Patwardhan, whoever is around. Yes, Aditi, go on. So Aditi, you will have to be a little brief. Hello, Aditi? Yeah. You'll have to be a little brief. Yeah, thank you.
I'll be speaking in brief regarding retinopathy of prematurity. ROP is a vasoproliferative disorder of the retina, which is uniquely seen only in premature infants. ROP is one of the major emerging causes of preventable childhood blindness because of improved levels of neonatal care, as the survival rate of low birth weight babies is increasing day by day. ROP problem has become so huge that World Health Organization has identified ROP as a priority area, particularly in middle-income countries and in urban areas of Asia. It has been seen that the number of infants blind from ROP in India will soon be equal to the rest of the world put together. There could have been 3 distinct periods which are termed as 3 epidemics of the ROP. First ROP epidemic was observed in large preterm babies in mid-50s because of unrestricted use of oxygen. The second epidemic was seen in late 1960s and 70s in very preterm babies despite attempts at titration of oxygen. Severe ROP in the Western world right now is limited only to extremely low birth weight babies which are identified on routine screening. India and other middle-income countries are facing the third ROP epidemic, which is actually a combination of the first 2 epidemics. It's because in India, the larger institutes are providing very good neonatal care, where only extremely premature infants are showing ROP. But in towns and rural areas, even large and more mature infants are having ROP. It's projected that approximately 18,000 infants will go blind every year in India. So where are we now in India? In India, relatively even large and mature babies with birth weight more than 1500 grams and gestational age more than 34 weeks have been reported to develop severe ROP. So let's have a quick update on the levels of ROP in India. India has accounted for nearly 10% of the worldwide estimate of blindness and visual impairment due to ROP in 2010.
In India, the incidence of ROP is between 38 to 51.9% in low birth weight infants. But very important thing is ROP is an avoidable cause of childhood blindness, so we should do screening and treatment properly on time. With this background, I'll move on to pathophysiology of the ROP. Usually, retinal vasculature begins to develop by 16 weeks of gestation, and full retina matures near term at around 40 weeks. In ROP, when ROP forms, there are two phases which are observed. In phase 1, there is relative hyperoxia with downregulation of VEGF, which causes vasoconstriction and avascular peripheral retina. In second phase of the ROP, there is abnormal vascular growth because of increased VEGF secretions, which causes retinal and extraretinal neovascularization. Main risk factors for the ROP are prematurity and low birth weight. Other risk factors are high exposure to oxygen for prolonged period, apnea, sepsis, anemia, cardiac defects, multiple blood transfusions, and respiratory distress syndrome.
Sorry, Aditi, can you just move on a little faster, please? Maybe
yeah.
you can go to what's the update, what's new in ROP?
Yeah, so basically the new in ROP is ICROP3 classification. The ROP classification in 2005 has got modified. There are few new terminologies. Instead of aggressive posterior ROP, we call the ROP as AROP now. Because it has been seen that the ROP can extend to the posterior retina. The second thing is persistent avascular retina, PAR, which is a new terminology which is introduced by ICROP3 classification. When we give anti-VEGF injections, the ROP regresses in early phases, but late recurrences are very common because of this persistent avascular zone. So we should observe the babies till the retina matures completely so that the late recurrences can be avoided.
Thank you so much.
Yeah.
Thank you.
Yeah, thank you.
I only have a quick comment here. Thank you. That was a lovely talk. And my quick comment is that a lot of us don't do ROP. It's okay. But ROP is a big problem. And we have a captive audience of pediatricians whom we can talk to. So what I'm saying is go to your local pediatrics association and tell them, I want to give a talk. Make sure the talk is not pre or post lunch. And make sure there's enough audience. And show some horror photographs of ROP, tell them some horror stories which are true about ROP-related blindness, and tell them, you know what, hey, you guys saved the kids, that's great, but then there is a blind kid. So make sure you get that point across, and I think we have done a lot of babies a favor.
Okay, so we just have one talk on allergic conjunctivitis, for which I think Dr. Rishikesh is at another session giving a free paper. If Reshma wants to make any comment on allergic conjunctivitis, you can quickly say something.
Good morning, everyone. Actually, I was not aware of this session. Sorry. So I'm not prepared with any slides.
No, you just have to give one comment because you're the discussant, you're not the presenter. And the presenter is somewhere else.
You can talk about the role of steroids in allergy. The UVA guys are here, they'll understand steroids. Yeah.
So I would like to only ask one question because we see allergic conjunctivitis a lot in all age groups, younger age groups. So I would like to ask ma'am, which is the best IOP measurement technique that you do in your clinic for these small children so that we are not using extra steroids and leading or pervading them to glaucoma, or they should not develop any glaucoma, cortical steroids or steroid-induced cataract or glaucoma.
Right. So any kid that's slightly older, of course, we do Goldman's. If not, you do an eye care. I have an eye care tonometer, which I share with some other practices.
So if you put a speculum, is it okay if you put
No speculum in children. The whole beauty
so
of eye care is you don't need to put any speculum. It's very kid-friendly. But the bottom line is don't use steroids recklessly. Scare the parents. Tell them if you see the box and it says D for dexamethasone or something D, run away. throw it away.
Yes, but
so scare the
usually
parents.
They don't come very often to you, or they don't come for a very good follow-up. They keep on hopping to many other people also.
True, true.
So it happens that finally the patient lands up in a very bad state.
I understand. Again, chair time. Very important in these chronic diseases is to spend enough time talking to the parents, telling them the dangers of self-medicating with steroids, tell them the accessibility. Mahi is here. Would you like to?
Would you like to say something?
Yeah,
he was actually the speaker, but you can just have a comment.
Because we are running into the other session.
So
yeah, please say a few comments. Thank you, Mai, for coming.
I'm really sorry, actually. I was running into
That's
another
okay.
session.
Just have 2-3 sentences so that, it's your topic on
Okay.
allergic conjunctivitis.
Okay,
Just give some 2-3 tips.
As actually, Madam, Doctor, I have been trained by Dr. MS Madam, and anything with ONE, I mean all those drugs, because at times the steroids have different name, and even we get confused which one is steroid. So anything ending with ONE or OL, perhaps those drugs need to be avoided. Or but sometimes, in spite of all the mast cell stabilizers or antihistaminics, the patient may not respond very well. So in those cases, we have to resort to a short course of steroids, steroid-sparing agents, or soft steroids like fluorometholone or loteprednol. Even when cases which do not respond very well, we can use a short course of prednisolone as well. But we have to be very careful. The patient need to be told well in advance what are the side effects of these drugs. But as far as possible, we try to avoid them. And especially in where I practice, Nagpur, there is a place called Chandrapur nearby, which is very polluted because of the mines around. And many of these patients, they do not respond even with the best of steroids. But somehow cyclosporine, in these cases, responds very well. Especially, but it's a longer acting drug. It takes a lot of time to act. So at least for the first 15 days, when cyclosporine is not working, you can cover that part using steroids. So.
Great. Thank you so much. So we'll wrap up the session. So remember, steroid-sparing agents early in allergic conjunctivitis is Dr. Rishikesh's take-home.
Yeah.
Thank you so much.
And we pediatric ophthalmologists, we're like a family. So we'll continue the reunion outside. Yeah. Thank you.
Thank you so much. Thank you, Dr. Meenakshi.